Welcome to the Better Never Ends podcast. We've made it our mission to share with you the expertise and wisdom of role models and leading experts in their field, teaching us about how we can be better, telling stories about their journey to better, inspiring you to discover yours. So some people call you the Anti-Psychiatry Psychiatrist, and I've not known you very long, but to me you are anything but that. You have the patient's best interest at heart from what I can tell so far. You've also had one of your ex-patients who has now fully recovered, in remission from manic depression and bipolar. And he wrote a very powerful blog about his experience and how he felt let down by the NHS and was very supportive of you and the way you helped him. And within this blog, he describes the case of Ignaz Semmelweis. And this is a case from the 19th century of an obstetrician who found, without really knowing why, that washing their hands with chlorinated lime water reduced the birth fatality rate to 1%. And he was hounded by his peers. And as a result, it never really came through as a scientific breakthrough. And the story was only revealed later, and you've just mentioned that it was actually a play in Soho. So why do you think your peers are hounding you and making it hard for you to innovate and share your story with the world the way you think it deserves to be shared? Why do you think they're calling you the Anti-Psychiatry Psychiatrist?
I think they get it wrong. In fact, it's not anti-psychiatry, it's pro-psychiatry, because medicine and psychiatry are about alleviating suffering. And when you see your patient suffer with whatever treatment is given, my view is that I'm always wrong until my patient recovers. If that doesn't happen, it's my fault, not their fault. So that's number one. Number two, I'm anti-tradition, whereby when you look at antidepressants, for example, they've been out for 60 years or 70 years, have been used. We know the data now that they don't lead to recovery. Very few people recover on it. Well, 10% to be more precise, 10 to 15, no more. And unless you reach full, absolute, total recovery, you've done absolutely nothing, because the death rates from mild depression, from cardiovascular disease, are 10% higher than the death rates from malignant hypertension in the elderly. So with hypertension, people fire 3-4 drugs at a patient, whilst with depression, they give one antidepressant for life or 2 antidepressants for life. So it just doesn't work, and that's where we fail. We stick to tradition, and my view has always been just find something better. So that's what I think they call me anti-psychiatry. Why they hound me, it's not because they're malicious. It's because it's very hard for someone to accept that what they've done or doing may have defects. And all the studies show lots of defects with antidepressant drug use and obviously other things like gabapentin, for example. And linking negligence to guidelines is a fatal error, because guidelines are always 10 to 15 years behind, and you cannot judge the standard of a clinician 10 to 15 years ago. You have to look at the standard today.
And what you mean by this is that people are leaning on those guidelines and saying, well, I don't use that method because the guidelines say not to.
Correct. And they're scared.
Yeah.
They're scared of deviating from the guidelines. When the guidelines tell you, the first thing, if you open any nice guideline, it will tell you your responsibility is to deviate from the guidelines in the best interest of the patient. Not only that, the guidelines don't cover all conditions. So if we look, for example, at bipolar disorder, which is up to 1 in 20 people on the street on the bipolar spectrum, the guidelines cover only 35 to 40% of them. The other 55 to 60% have no guidelines in the UK. And that this condition accounts for 200,000 attempted suicides in the UK, which is a hell of a lot. And not once, but repeated. And there's no guidelines, neither for management nor for treatment. So that's the problem with guidelines. So am I anti-psychiatry? No, I'm pro-psychiatry. Am I anti-tradition? Yes, I am, and I say it unashamedly, because even what I do, there's better. There's always better. and we have to look for the better solution. Of course, it has to be safe, but we always have to look for the better solution, and we never rest until the patient is totally well. If they're not, then we have failed.
And when I look at some of the papers that are out there on the methods that you propose, the treatment effects seem incredibly powerful compared to traditional methods. So can you just tell our listeners a bit about your methods then, so they can get a bit of an idea about this innovation that we've already started to speak about?
Okay. So in 2007 was the first time when I read about rTMS, repetitive transcranial magnetic stimulation. And I wanted to bring it in straight away in the UK. It was not licensed, so it was impossible to bring it. I noted that in 2007 was the year when it was introduced in Israel. 2002 was in Canada. A year later, 2008, was in the US. It hadn't come to Europe. And I was treating a case of a lady whereby I had fired just about everything you can imagine, and nothing worked. She sat in front of me, and I said, the only thing I have left is ECT, electroconvulsive treatment. And when I mentioned that, she started crying there and then. And I thought, surely there must be something better. Lo and behold, at the time, Rafael Elba, my colleague and friend, called me and said, would you like to, do you know what rTMS is? I said, yes, of course. And he said, would you like to open a unit? I said, absolutely. Is it licensed? He said, yes. I said, fantastic. That was in July 2012. It was licensed in January 2000. And I told Rafa, let's get it in. And in November, we opened the first unit. At the time, I tried to raise capital to open a unit, get a machine, get PR, advertise. It was licensed, so you could use it. And no banks would lend anything, so I had to put my own money in. And I put just about the last penny I had that night from opened the unit. And by God, the criticism I faced. Well, he gives quacky treatments. There's no evidence to it. Insurances refused to cover it. Bupa allowed one or two cases. AXA PPP refused point blank to cover it. They said, we only cover things that are approved by NICE. I said, fine, I'll get you NICE. And then we wrote to NICE. I told Rafa to write to NICE. So we wrote to NICE and said, look, guys, what we did. By then, we had treated 50 people. And the recovery was just remarkable. They did so well. So, and in a very short time. And NICE wrote to these patients and then started their review. And then a year later, and that was in 2014, in 2015, NICE approved. So it became approved by NICE. At that point, the first NHS unit opened in the UK in 2016. My view is I can't be the only one treating it. I wanted it available to everybody. And I tried and it worked. So now it's available in many places. And it works. It has no side effects, generally speaking, very mild side effects, if anything, like headaches, which respond to paracetamol. Normally, headaches don't respond to paracetamol. That headache responds to paracetamol. Yeah. 1 in 6,000 has problems sleeping. Well, I had problems sleeping last night. 1 in 6,000 had a partial seizure. 1 in 6,000 had a manic episode. These things are 1% on the street. So really, it doesn't have any drawbacks, and it works beautifully by what we call neuroplasticity, whereby the nerve cells regrow effectively, and the pathways form and reform, which is something when I was studying medicine we were told doesn't happen. Now we know it happens.
Yeah, and this is something as physiotherapists we're very much guiding and supporting through our rehabilitation, is just as much the neuromusculoskeletal recovery as it is the physical tissues of the body. It's the brain cells, the neurons that we're stimulating through relearning, and this just seems like an add-on potentially to some of the work we do, which is one of the reasons it really jumped out to me, is that chronic pain is something I know you started to research as well, and it's really tricky to treat when you're just using physiotherapy on its own. But by the sounds of it, if you start to combine different methods and different ways of treating, you get a better effect. And neuroplasticity it's such an amazing thing that the brain has the capacity to do this. And it's not been long since we thought it could do it at all.
Yeah.
I read the book, The Brain That Changes Itself. It's a lovely book to read, a really enjoyable read. And it was written in or certainly some of the case studies are from times when people just didn't believe it could happen.
Yeah.
That the brain couldn't change at all. Once you reach a certain age, that's it. It stops changing.
Yeah, they used to say 18.
Yeah, we now know that that's complete rubbish, and it's continually changing for our whole life. So how do you think that happens? What do you think the mechanisms are that this treatment is supporting neuroplasticity?
Okay, I'll simplify it as much as I can. We all rely on tiny bodies in the cells that we call mitochondria. These mitochondria are the basic unit of the cells that produce energy for the cell. They need oxygen and they need glucose, and when they take oxygen and glucose, they work through what they call cellular respiration, whereby they burn glucose and oxygen to produce energy. And for the cell to be healthy, we need that. When you look at stress or depression or any what they call oxidative stress, any stress will actually damage the mitochondria. So when the mitochondria fail, the cells fade, the function of the cell fades. And when that happens, many functions fail, including neurotransmitters, the communication between one cell and the next. So neuroplasticity is an ongoing process that requires mitochondria. Basically, the cell repairs itself by growing what we call microtubules, like scaffolding inside the axons, inside the cells, and inside the body of the cell itself. For this growth to happen, it needs the energy from the mitochondria. If your mitochondria are knocked out, that repair will not happen. And that's when we fall prey to various diseases, various psychiatric diseases, neurological diseases. And what rTMS does, it stimulates the growth of the microtubules. It increases oxygen and glucose utilization in the brain by 33% to be specific. It increases the blood flow. It increases the activity of the nerve cell, whereby it would use more energy because you get more oxygen and glucose, and the process kickstarts, and the neuroplasticity develops, and the cell grows. And when the cells grow in size, they communicate better with one another, hence the neurotransmitters work better with one another, and then you get recovery. We shouldn't settle with anything less than recovery. If we did not achieve recovery, we failed our patients. And I always argue, if you say the patient responded to treatment, that's not good enough. They have to recover fully. Even from pain, we have to make sure that they recover fully. If there's residual pain, then we try and help them to manage it better. But still, we have to aim to full recovery.
I completely agree with this sentiment, because it's something that I believe is completely wrong about the way we manage chronic pain at the moment. This idea that people just have to live with it, that people just need to keep living despite it. And that although sometimes a change in mentality can help someone make the first steps, I fully agree that full recovery is the aim, that we should be aspiring towards helping people be pain-free entirely.
And depression is key. Anxiety is key. So I was reading about depression pre-surgery. Any surgical procedure that you do, if you have depression before the surgery, your death rates increase by 20% in the first 30 days of the major surgical procedure. If you have anxiety, it's the same. If you use SSRIs, it's the same. The death rates increase by 20%. If you look at back surgery, 70% of those with back surgery, if they have pre-existing depression, will end up in chronic pain. So only 30% will benefit, but 70% are doomed to have chronic pain. So we must screen for psychiatric conditions before we operate, or before indeed we do any intervention. Because even if you do physiotherapy with someone who's depressed, you will never have the results.
The outcomes are much worse.
Yeah, they are much worse outcome. And people despair even more because they tried everything. They go to see you, they try, and it doesn't work. Then they lose.
It increases their sense of despair. They feel like a failure.
Yeah. I'd rather not intervene at that level and just focus on the psychiatric state and then intervene later. But if you intervene early with any other intervention than directed at treating depression, then you actually incapacitate the patient even more, where they tell you everything was tried and nothing works.
I often get this idea of like, I've tried physio, I failed physio.
Yeah.
I don't believe that. I think the physio failed you. I think that there are other ways of doing it. You just haven't found the right physio for you, or you haven't found the right treatment method for you. And what you're prescribing is a much more holistic, collaborative way of treating the person, that it's an MDT, a real MDT around the person. I understand you described that, and we'll get to that shortly. I don't want to lose my question around mitochondria, actually, or even my reflection around it, because that really interested me when I was reading your paper earlier. The fact that you sense that one of the main functions of how it works is via the mitochondria, the energy powerhouse of the cell. Absolutely.
Yeah.
This is something that I did a sports science degree before my physio, and it was the mitochondria is, an absolute key part of that. It's important for health. It's important for performance. And I wonder whether that's partly related to why exercise is so powerful for mental health conditions as well, because it is a stimulant of the mitochondria. It helps to grow the mitochondria. And also, as we age, our mitochondria do wear away. And I wonder again whether that's why mental health conditions can increase as we age, certainly as dementia and neurodegenerative conditions increase as we age, whether the mitochondria is a real center point of what we're discussing here.
It's mitochondrial dysfunction, basically. Even motor neuron disease is mitochondrial dysfunction in the anterior horn cells. So when you look at any condition which is related to CNS predominantly, you will find that mitochondrial dysfunction is key. So anything to treat mitochondrial dysfunction would be perfect. Alcohol is a mitochondrial toxin, direct mitochondrial. Why did we have such a catastrophe with COVID? Because COVID infects mitochondria directly. So when it does that, and it does that preferentially in the brain and in the heart, these two. And that's why you have young, and so does the vaccine. It hits so the complications of the vaccines that happen are due to mitochondrial dysfunction. So at the end of the day, any treatment should be directed at supporting mitochondria, not damaging mitochondria. So I tell all my patients, if you were given a Ferrari for free, gold plate, and you were told the only thing you need to do, it's insured, you'll have all the petrol for life, basically all you need to do is look after it. Would you hit it with a hammer every morning on your way to work?
Sure wouldn't.
If the answer is no, then do not drink alcohol, because it's a mitochondrial toxin. And the most precious thing we have is the brain. It separates us from chimpanzees. So with something that specifically infects or damages the mitochondria, we need to be very, very careful. Caffeine does the same. So caffeine produces a stress response in the body. Cortisol, adrenaline, noradrenaline rise. When you have a rise in cortisol, there is mitochondrial dysfunction. The mitochondrial membrane becomes thicker. It becomes more sluggish. The passage of oxygen and glucose becomes slower. So then it becomes harder for the cell to function.
Why do many of the studies around coffee then suggest that a moderate amount of coffee is actually beneficial for health?
They look at specific things. They don't look at the full picture. That's the problem. So when you look at, even with antidepressants, it's the same. They tell you antidepressants reduce mortality from cancer. No, but they increase all-cause mortality. It doesn't matter if it goes down in cancer or it increases somewhere else. So caffeine is the same. Your cortisol will rise to a high level in the morning and will go down as the day goes by. We were designed this way. We were created this way. We don't need to boost it in the morning. You just wake up in the morning, you'll have that level. Because we've been using these substances like caffeine caffeinated versions, even decaffeinated versions, have other methylxanthines, which are similar family to caffeine. Our bodies became used to it. So the more we drink that, the more cortisol we get, the more mitochondrial dysfunction we get. So you notice that people start with a coffee, then they tire later. Okay. And then they need another coffee. Then they start again, they tire later. To give you an example, I invented a rebreathing mask when I was a trainee at Guy's. And at the time, we wanted to see how it impacts oxygen and carbon dioxide at the end breath when you breathe out. And we did normal controls. It did exactly what we wanted to do, and we were very happy with that. So we said, we treat people now with panic attacks. So we recruited 50. I asked them to stop tea, coffee, hot chocolate, cola drinks, decaffeinated versions of drinks, and alcohol, and come back a month later. Out of the 50, only 5 had symptoms. 45 did not. So the study collapsed in a heap because in 6 months, we recruited 5.
You cure them with your control method.
Just stop the coffee and the panic attacks vanish and the anxiety vanish. Just stop the coffee, tea, hot chocolate, alcohol, and they're fine. So we ran out of patients. So the idea is since they opened Starbucks and the lot, the number of patients I see with anxiety disorders shot through the roof. And typically they come to you, face red, they go to the toilet a lot, they wee a lot, they may have problems sleeping, they may be tremulous, they may have a fine tremor. And these guys who have chronic pain will be worse because anxiety will increase your arousal. The more aroused you are, the more you will perceive sensation. So if you're very aroused and I touch you, jump. If you're in coma and I slap you, don't move. So when you give them coffee, you make them hyper-aroused. So I tell all my patients, stop all these things first and then we'll talk. And most of the time, they're fine.
And the ones that aren't fine, what's your method? Because I know that we've spoken a bit about the rTMS now, but what does that involve then? So someone who's changed their lifestyle, still struggling, still having some level of chronic pain or mental health condition.
We need to identify what kind of mental health condition it is. That's the first thing. And with pain, the problem is that if we don't address the mental health, you will not be able to address the pain. So if someone tells you, I have chronic pain and I have no mental health issue, that doesn't make sense. The simplest thing is chronic pain gives you stress, doesn't it?
Yeah.
Constant pain will give you stress. The inability to do things will stress you. Now, stress alone is a mental health condition. They call it stress-related. Okay? For that, there are multiple methods we could do. With rTMS, there are specific protocols you can give. And there's something that I developed, a concept of, that I haven't seen in the literature yet. I'm going to be shot down for that now. It's what I call intra-traumatic stress disorder, not post-traumatic stress disorder. Post-traumatic stress disorder is something that happened and is gone. It's easier to treat that. Intra-traumatic is when the stressor continues. And it could be life-threatening, say victims of stalking, for example. Even when the stalker is in prison, the threat is always there. Yeah? And that's what I call intra-traumatic. So chronic pain gives you intra-traumatic stress. A diagnosis of cancer is intra-traumatic stress. And what I tell patients, if you have intra-traumatic stress disorder and I say, fine, it's because of that gorilla. You're in the cage with a gorilla. I'll take you out of the cage, treat you, then put you back with the gorilla again.
Yeah, because CBT is typically used for post-traumatic stress disorder because you can rationalize this idea that it's behind you and you can move beyond it. You can change your beliefs about the stress that was there. You can recover. But as you say, if you are in the stress, then absolutely, why wouldn't your system be stressed by the fact that you are in pain and struggling and suffering as a result of being in pain?
Not only that, but the stress can increase. So the stress is not at the same level all the time. So you may CBT it out of existence with a lower level, but then one day it becomes overwhelming. And that's when you're floored. And that's the difficulty. So the gorilla becomes supercharged, like Superman gorilla, as opposed to a tiny gorilla. And this unpredictability is exhausting in itself. So my view is to apply rTMS with the stress-related protocols in these people to reduce arousal, reduce the stress response, and then also treat. There are protocols also for pain, which you can use. So typically when we treat people with stress-related disorder, we use an inhibitory protocol that reduces arousal. And then we do EMDR or whatever method you do. With intra-traumatic stress disorder, I've treated a number of people. And you can see on our website reviews, on the Google reviews, they say in PTSD that I had PTSD, but the stressor was ongoing. And they had a treatment, and they say the stressor continues, but we're fine. It changes the way you react to stress, that's the neuroplasticity. The more your brain does something, the better it gets at it. If you start with stress and you continue with stress, you become perfect and excellent at being in stress. What rTMS does is stimulates the positive pathways 150,000 times to 200,000 times. It's as if you have a positive thoughts that you repeat to yourself 200,000 times.
How does it do that part? Why is it not stimulating the negative pathways?
Because we target pathways that are inhibitory in the states of high arousal. And that's the problem with the understanding of what you treat. So to me, what makes more sense is the diagnosis, not the rTMS. So for example, if you look at a study called Bright Mind study that was done in the NHS, I think 5 or 6 centers, they identified what they call treatment-resistant depression, or TRD. And they gave them two protocols of rTMS, one called ITBS and one left side 10 Hz. What happened when you look at the data of the study, it was quite alarming. 22% only recovered, which is an 80% failure rate. That's really bad. There were, I think, 17 attempted suicides out of 235 people. So you're looking at 6% attempted suicides during the study. There was 1 mania, 1 psychosis. It's too high for rTMS. So rTMS, when you look at it, is 1 in 6,000 mania. So that one's 1 in 200, 1 in 100 mania or psychosis. And that's because they used excitatory protocols, not inhibitory. So you need to identify the diagnosis correctly first, and then apply the correct protocol, and then you'll get the result. And I think that's the problem with now, in the UK, they ruled out 52% of primary care depressions from any guidelines. It's what we call depression with subthreshold manic symptoms, where people are depressed. Yes, we accept that, and I tell the patients, I can bring a donkey to tell me that you're depressed. But their minds are racing. And if you Google depressed with racing minds or racing thoughts, you will find many people who put, there's a few articles mailed online about people who felt very suicidal then. That's when the mind goes like a tumble dryer of negative thoughts, but they're very depressed. And you'll find in chronic pain that this can happen. Now, if you give them antidepressants, they actually deteriorate. If you give them rTMS excitatory protocols, they deteriorate. And that's when people despair even more. And if they're stressed and you give them that protocol, some improve, but at a high frequency. But the best protocols to give are the inhibitory protocols.
So essentially, the alternative, what they were doing was fighting fire with fire.
Correct.
Yeah.
And basically, when they call it subthreshold bipolar disorder. It's 60% of bipolar disorders. NICE deliberately excluded it in 2015 from its guidance, and that is deliberate. They recognize the concept of bipolar spectrum. They say apart from 1 and 2, we're not going to cover anything else. That leaves 60% of the bipolars, but these guys are 52% depressions at the level of the GP. Let alone by the time they come to a psychiatrist, you're looking at 70-80%. By the time they come to someone like me, they're almost all like that. And the problem is that people find it hard to accept this is bipolar. it is, and I tell them it is subthreshold. I can't make the diagnosis of bipolar, but you've got features of it. And I tell them it's like shades of grey. You've got black, light grey, dark grey. Even white has got shades of grey. And I tell them it's the entire spectrum. So if you fail to identify that from the beginning in your patients and you give them antidepressants, it's not going to work. It's going to get worse and worse and worse. And you see patients who tell you, I'm taking antidepressant, I'm going nowhere, or I'm deteriorating. They feel very agitated first when they take it in the first few weeks. And then if they increase the dose at that point, the GPs, that makes it even worse. So typically they come off it. Patients come off it themselves. So this is the biggest work. And these guys, if they have chronic pain, it is heightened because they're so aroused. They look calm on the outside, but I use the term, you look calm, but you're volcanic inside. They say, yes, volcanic is. So if someone listens to me now and they identify with that, they must go to their doctor and tell them the antidepressants will make me worse.
And for these people, they need the inhibitory rTMS.
The inhibitory TMS, yes. The problem is that it's not widely available and there are no guidelines in the UK to treat this population. The only thing is that there's one paper from Cardiff University which identified this, and it was by Smiths and Nick Craddock, and they say that's potentially a large number of people, and in that study 52% of major depressive disorder diagnosis in GP practices in Cardiff and Newport had this. And they said in that paper that these guys will potentially do much worse on antidepressants in the long run. And they have to be identified. And they used the questionnaire to identify it. To identify, it's called the HCL32 questionnaire, which has the ability to pick it up at 90%. So it's 90% right. So if you go by the balance of probability, there's only a 10% chance that this is not the bipolar. And if I were to tell you there's a venture with a 90% failure rate, would you go for it? No. So I would probably recommend more thorough assessment of all patients with chronic pain. We need to look for signs of arousal. There's a very good questionnaire called IES-R that will detect the stress response. If it's above 11, we have a stress response, the cutoff point. The second test we do is the PHQ-9, which identifies depression, 85% accurate, and the GAD-7. These are short questionnaires, WHO questionnaires, which will identify depression, anxiety, and stress-related disorders. And I think these three are essential. And the second step is to identify use of stimulants like caffeine, tea, chocolate, hot chocolate, alcohol, because people will cope with alcohol. They will drink to feel less pain. Problem is that alcohol is a mitochondrial toxin, and whilst it may sedate you, later on it will cause problems.
And once these sub-issues are then identified, how do you then help that person through the complexity of recovery?
Okay. If they are stress-related disorders, if it is post-traumatic stress disorder, the first thing I would do is something like EMDR, if it's post. If it's intra-traumatic, the best thing to do is rTMS, followed by EMDR if there's a need to do it.
EMDR?
Eye movement desensitization and reprocessing. It's a very simple method of treatment. Doesn't require genius to work it out. They made a song and dance about it. They need training, accreditation, this, that, the other. I did in 2001. I did the accreditation then. I was accredited years and years ago. I treated well over 2,000 people over the years. I found that, so normally you need 8 to 12 sessions. I do it between 1 and 3 sessions. And the reason for that is I prolong the period of exposure. Now, technically, they'll argue this is not EMDR. In my view, it is EMDR with prolonged exposure because I do exactly the EMDR. And people do very well with that when it's post-traumatic. But when you try and do EMDR in the middle of the trauma, you hit a brick wall. That's the first thing. The second thing is rTMS. There's inhibitory protocols that you should use. If they have anxiety disorders, the treatment should be first eliminate stimulants of all kinds and alcohol. If that doesn't work, then you move to active treatment. I haven't prescribed antidepressants since 2004, which is 21 years. I have the best results in the world, hands down. Audited, peer-reviewed, published in peer-reviewed journals, lectured on in international conferences, without antidepressants at all. Bizarrely, there's an article in the British Journal of Psychiatry, if anyone has interest to look at. It's called Benzodiazepines, Time to Return to the Evidence. And if you Google these words and you look for that, you will find they tell you that the evidence show that benzodiazepines are not really addictive. And one of the reasons that they've been vilified is because of the drug companies. They wanted to make way for the antidepressants. So the best thing to do is to remove the major competitor and bring in the new drugs. But there was a study in Denmark, if people look up Danish register benzodiazepine-related agents. It's a study of 951,000 people, followed up for a period of 20 years. They found that the rate of dose escalation, which is the first step in addiction, is 0.37%. That's nothing.
Doesn't sound particularly worrying to me.
No, it's below 0.5%. So if I tell you Caffeine has less than 0.5% chance of making you want more, would you tell me it's addictive? No. And that's a very large study, published. People can find easily online if they look for it. And I would use benzodiazepines initially. If rTMS is there, I would use rTMS because there's something called effect size. And always when you look at any treatment, you look for the effect size. The effect size is how effective an intervention is. It starts from 0, which means did nothing, ends up at 1 typically, whereby it's a big effect size. So when they look at antidepressants in the treatment of depression, the effect size is 0.3. 0.3 is small. It's not a big effect, which means it will make a small improvement in matters. It will not remove the problem. If you look at fibromyalgia, for example, the effect size is 0.2, which is small. Placebo is about 0.2. If you look at lamotrigine in bipolar disorder, is 0.2, 0.25, which is very small. If you look at rTMS in anxiety, it's 2. So it's 10 times more effective. If you look at rTMS in stress-related disorders, it's 0.88. If you look at EMDR in post-traumatic stress disorder, it's 1. So these are big effect sizes, which means it's very effective in the intervention. The Zamar protocol that I developed for the treatment of resistant depression and rapid cycling bipolar disorder of any kind, whether it's 1, 2, or subthreshold, is 2.6. So it's a mega effect size. And the whole idea, when you weigh the risk-benefit analysis, you need to look at the effect size and you need to look at the risk. So with antidepressants in anxiety, the effect size is 0.4, 0.5, somewhere there. 0.45, I think, is the highest. With benzodiazepine, it's 0.35. But when you look at antidepressant risks, they're much greater than benzodiazepines. So I would go for benzodiazepines in my equations because the risk is lower. And they are not addictive. We've got a study of almost 1 million people. That's huge, which shows that they don't escalate doses. And of those, only, I think, 3% moved on to become long-term users. So the key is that you reduce arousal, you treat the pain. My view with those patients is this thing has hit you with everything it's got. So we have to hit back with everything we've got, which is you, me, my machine, psychotherapist, all of us get in together to help the patient. And the most important member of the team is the patient.
Yes.
I tell the patients, I'm your advisor. Nothing but your advisor. You're the boss. So it's in your hands. I'll guide you, but I need you to lead.
Yeah, I often say I might be the expert in physiotherapy, but you're the expert in you. we need to work together.
Precisely. And I tell them, you're the most important member of the team. If you go on strike, the whole thing stops.
And your method sounds like the kitchen sink approach. I often use the kitchen sink approach with my patients. We're going to throw everything at it and the kitchen sink.
You have to. You've got no choice because it floors the patient.
Yeah. And I don't mind what exactly has worked in the end. Likely a combination of lots of different things. I'm not precious about which part of my methods work. I just want them to get better.
We don't need a hero.
Yeah.
That's how I see it.
Patient is the hero.
The patient's the hero. So we don't need a hero. And the way I see it is, if the patient takes control and feels empowered to decide, and you're their advisor, and you basically, they ask your advice, and you tell them, you can do this, you can do that, you choose, and you give them all the options, then you're likely to succeed. To me, consent is very important, so I developed these consent forms for just about every drug you can imagine. So for antidepressants consent forms, I put the studies on the mortality, I put the studies on the effectiveness, I put the studies on the withdrawal symptoms, and I put the studies on benefit, and I tell them to choose. And if the risks outweigh the benefits, they have to take a decision, especially in the elderly. There's a very, very disturbing study. I don't know whether I talked to you about it. It's in the BMJ. So if anyone who's listening looks up in the BMJ, adverse events, antidepressants, older adults, BMJ, you will find that the absolute death rates increase. The 1 year death rates, if you have no antidepressants, is 7%. If you take a tricyclic, it's 8%. If you take an SSRI, it's 10.6. If you take venlafaxine, duloxetine, mirtazapine, it's 11.4. That's the 1 year mortality rate.
And these are big numbers, weren't they, these studies?
They are big numbers.
So when they're changing in those percentages there, that's meaningful change.
It is meaningful. You're looking at is a population of 60,000 people. 57,000 had antidepressants in 570 GP practices. So part of consenting the patient is to let them know what the risks are and to give them all the options, and then they choose. My vision is I want rTMS to be everywhere. The other one that may be helpful is TDCS, which is the machine you can buy at Boots for £400 and you wear it on your head half an hour a day. Less harm, far less harm than you would get with antidepressant. The other thing that's important to know, and I always look for it, and I opened my eyes to it only recently, is what we call SIBO. Have you heard of it?
No.
Small intestinal bacterial overgrowth. If you look it up, it's a very common condition, and it leads to malabsorption. So I had a patient who was taking an antidepressant. I'm trying to reduce it. So she was on a low dose of the antidepressant. And she was clearly in withdrawal symptoms despite taking her medication. The same dose, it's steady. Yeah, but then suddenly she deteriorates. And I checked blood levels, they're very low. We do the SIBO test, it's positive. So the level should be between 100 to 400. Her levels were 64. So she clearly has no levels at all on 75 milligrams. That shouldn't happen. We treated SIBO with antibiotics. It takes 10 days of antibiotic treatments. The level went to 463. So she 473, sorry. So obviously she was not absorbing it. And that's another reason for the drug treatment not to work. The ingestibles need to be absorbed. If their gut health is not right, they will not absorb. If they don't absorb, no treatment you will give orally would do anything. It just doesn't even get in. So that's something to always check, or tell the patient to tell their doctors to check them for it.
How easy is it for people to get this MDT approach, this holistic way of thinking about their recovery? Because there's firstly the lack of appreciation in the wider medical system. There's then the financial implications of them being able to access care like this. And your mission, your dream, which is clearly coming across, is that you wish everyone to have access to this kind of care.
Yeah. The problem is cost. It's multiple specialists. The NHS is severely underfunded. And it reached the level whereby doctors don't make the diagnosis anymore. The GP makes the diagnosis, sends it to the mental health team. The mental health team diagnoses phenomena, anxiety, depression. Or if you go to the infectious diseases specialist team, and they diagnose you with fever. These are phenomena, these are not diagnoses. So, and then they give treatment. Depression equals antidepressant, psychotic equals antipsychotic, anxiety equals CBT. There's no thinking. And what I understand is the duty of care of doctors now in the NHS is no longer there. It's the trust that does it with a team. It doesn't work. I'm not sure it would work in the NHS setting because of the severe funding. In the private sector, it works. But in the NHS, I don't see it work. I hear expressions like, we don't believe in it. And I say, well, what do you mean you don't believe in it? It's record. It's a disease record. What do you mean you don't believe in it? It's not a religion to choose whether you can believe in it or not. And one of the bad scenarios I've seen is a patient of mine ended up with Lyme disease. And when I was walking in Richmond Park, I saw warnings about ticks and Lyme disease in Richmond Park. So it exists. It's not that it doesn't exist. And this patient deteriorated and was admitted to hospital. The treating doctors said he doesn't have Lyme. They did a test, which was negative. You can have negative tests. It doesn't mean if the test is negative, it's not there. You have to repeat it again. So or do another test. So with COVID, for example, they used to do 3-4 tests in ICU to say this is COVID. So they said dementia, and they discharged him with dementia as a diagnosis. They isolated Lyme disease with another test, and he's receiving treatment. But the NHS tell you, we don't believe in it. What does that mean, we don't believe in it? And they developed pain. So he had joint pain, muscle pains, incapacitating pain from the Lyme disease. And he was stung by a tick, which he remembers clearly. And he identified the day when that happened. So I'm not sure it would work in the NHS. I think it would have to be the private sector, sadly. But sadly, a lot of people now are, you pay tax and you don't get the benefit. So in the NHS, though the waiting times are increased, 130,000 people died on the waiting list in 2023, I believe. That's more than the Second World War deaths. So I argue that Hitler and Hirohito combined failed to kill as many as the NHS did on the waiting. The yearly toll of 130,000 in 1 year is unheard of. In the Second World War, the death toll was 80,000 a year, not 130,000. So I'm not sure it would work in the NHS. I don't know how it would work. Maybe if the tests become cheaper, you educate the doctors. Problem you have is when you bring something new, you get attacked immediately.
Which is what we described at the beginning of the episode.
Correct. You get attacked immediately. Oh, he uses things that are American. The best example I can recall of that was EMDR.
Is that a genuine critique? That someone has labelled it as because it's American, that's...
I've heard that. I've heard that with EMDR. So EMDR now is the Bible for treating post-traumatic stress disorder. Back in the early 90s, I was sitting in the NHS in some meeting, and some consultant said, well, this is American, this is not for us. And at the time, they were doing debriefing with the military. So they would send the military to war, and they'd send teams of debriefers. They found that debriefing makes it worse, not better. They continue to debrief.
Because they're exposing them to the stress.
Again, yeah. And I argue, you bury the dead. You don't keep them in your lounge looking at them every day. You bury them. So do elephants, so do giraffes. They walk away. So the problem is that they continue to do the debriefing, arguing that EMDR is American, there isn't the evidence, well, we don't see that. Same with rTMS. Well, there isn't the evidence. So when I brought rTMS in 2012, They said, well, where's the evidence? I said, yeah, I presented in a conference a poster of the first 10 people we treated. And somebody asked me, did you do a control group for that? I said, why do I need a control?
That wouldn't be ethical.
No, they're meta-reviews of meta-analyses of randomized control trials. There were data on tens of thousands of patients with controls. Why do you need to do 10 against control? Not only that, I asked the guy, when you give them Prozac, do you do a control group as well? Or you just give them Prozac? It's licensed. So people, when they see something new, they regard it with suspicion that it's insufficient. The data is from abroad. It's nothing to do with us. That's completely the wrong way to look at things. We learn from one another. And we have to adopt practices, good practices, evidence-based practices from anywhere in the world. Not restrict ourselves to what's here, and that's it. That's what we've done over the past 20 years. And if we don't have the data, we're not going to do it. So with rTMS, we face that problem. ETNS, which was a treatment for ADHD I introduced in this country in 2012, had remarkable effects, no side effects. I faced the problem. I was the only prescriber. It was licensed, but I was the only prescriber until the company withdrew it. With the Zamar protocol, same problem. It's in guidelines now in the UK, but you get a headache. They keep arguing. So now I tell people, if a doctor takes you off it, go to the police station. Say it's a treatment in guidelines that saved my life, and this doctor is insisting to take me off it. It's willful ill treatment. So whatever they see is new, they panic because they have to compare it to the existing guidelines, which are 15 years old. And good luck to that. It just doesn't work.
At the start of the episode, we referenced one of your patients who wrote a blog online, Tom Robinson, and he was particularly angry at the NHS for not allowing him to carry on the treatment that you had prescribed so that he could continue to access it on the NHS. What is that precise part that he wasn't able to access? What was the thing that he was frustrated by there?
Well, the treatment that people find hard to access is high-dose thyroid. High-dose thyroid hormone, we discovered genetic mutations in this population, which means that they can't convert it. The question is, why do these people tolerate mega doses of thyroid that if I give to you, you will explode? And you try and, rely on evidence-based medicine, and opinion-based medicine trumps it in England. So they keep arguing it's dangerous when the patients are well. And when you remove the treatment, you put the patients at risk. Why? If the patient is well, it's not just one patient, it's all my patients. They get, there was an elderly patient of mine who used to take her thyroid in a little bag and lie to them and say, I don't take anything. When she goes to hospital to get admitted, elderly people get admitted for various things. And she used to go to the bathroom to take her thyroid because they stopped her thyroid 3 or 4 times, and 3 or 4 times she relapsed. So it's not fair on these people. They need the treatment. It keeps them well. Why stop it? And the worry I have is that clinicians tend to worry about themselves, patient.
The litigation side of it.
Not the litigation, the regulator, the GMC. Who's going to report?
Because of the guidelines.
Yeah, and they completely ignore the fact. I argue we make guidelines. So I brought rTMS in this country and made the guidelines. I developed the Zamar protocol and it entered guidelines. You make guidelines by bringing innovation, but if you rely on guidelines to make innovation for you, it will never happen. Just will never happen. So, when you're outside the academic world and you bring something new, you get attacked. So when I invented prolonged premature ejaculation, I faced major headaches. They refused trial. When they did the trial, they refused to publish it when it was 10 times better than what was happening. It was done in Karolinska in the end without me even knowing. Doing it in Karolinska in Sweden. And the results were very impressive with no side effects. But I remember a doctor who wrote guidelines. He said, I will include it on the experimental side. I said, look, if you do that, I'm going to report you to the GMC because you're recommending antidepressants for premature ejaculation when they're not licensed. Prolong at the time was licensed. So you're recommending what is not licensed as a treatment, and what is licensed, you said use it for research. That's completely, especially when it doesn't have side effects. So anything new scares them. That's all I can say.
So we're starting to unravel part of the reasons why people struggle with innovation here. One of the other things you mentioned earlier was around how pharma companies would essentially report on the addiction rates of benzodiazepines inaccurately, by the sounds of it, in order to clear the way for antidepressants. I read the House of Pain last year about the Sackler dynasty and the OxyContin scandal.
That was really bad.
Well, I mean, an incredible book, but such a frustrating read to see time and time again. They keep getting away with it, and the legal system lets down the people who keep dying and addicted to this medication. So it sounds on a similar level here. The antidepressant side, perhaps maybe not quite as cynical. I don't know. What do you think?
Let me explain. The argument that benzodiazepines were vilified partly because of the move of the pharma industry is not my view. It's actually published in the British Journal of Psychiatry since 2018. It's there in writing, in the article I mentioned. That's the first thing. The second thing is the way innovation happens in medicine now is by the drug companies. So the pharma companies come up with a drug, and they say, they do a study of some kind or another, and then they say it's efficacious. They use terms that, to me, are unintelligible to people. Efficacious instead of effective. They say effective in reducing symptoms, which to me means you fail, basically. The effect sizes are rarely mentioned, and if you mention effect sizes, people don't even know what it is. And they get a drug license, then once it's licensed, it enters guidelines. Once it enters guidelines, if you deviate from it, you have a headache. And there's no thinking involved. So partly the pharma industry, partly the guidelines, partly the regulators, partly the colleagues, and partly the fear that is instilled in patients about trying something new. So, for example, I showed you earlier stem cells. I had stem cell injection, the spine, when the only option I was given was spinal fusion. And the MRI scan shows a complete regeneration of the bone and the cartilage. I was told when I said I'm going to do stem cells that it doesn't work and you may get an infection and it may be catastrophe. So there's always a focus on the negative. Thank God I had the stem cells, because spinal fusion would have been much more of a disaster for me, at least, than the stem cells.
It's hard enough as a physio to treat. Yeah.
Yeah, and you've seen the scans. I showed you the scans. You can see a huge difference. And the friend of mine was a neurosurgeon and told me it's compelling. He's never seen anything like it. So if it's new, they're scared. The drug companies do rightly produce drugs, because you do need drugs. But I think the innovation needs to come from many quarters, from universities, from drug companies, from individual doctors, because you have innovations that happen from individual doctors. In the past, it used to happen. Best one is Semmelweis. Wash your hands.
Sure.
Yeah, it's a very simple observation, because we observe as well as treat. We don't just treat. But nowadays, it's become that doctors are unable or scared of doing anything new. Whether it's the NHS trust policy, whether it's the guidelines, whether it's the GMC, whether it's the regulators of any other kind, it becomes very difficult. But to go back on what I was saying, the question was, with antidepressants, it's not as cynical. I stopped using them altogether, because if they benefit people, they'll do that in primary care, not in my level, because by the time they come to me, antidepressants actually cause more harm than benefit. Not only that, they do a 6-week trial and then license the drug for life. So people take the antidepressants for years and years and years. I saw a patient yesterday who had antidepressants for 15 years. Not a single clinical trial in both 15 years. Yeah, and they rely on what they call post-marketing surveillance, and nobody surveils. Nobody writes anything. Nobody does anything. So it's just not something I would do. And the effect size is absolutely crucial. people don't know what it is. So if you read about the dementia drugs, recently there was a big story about dementia drugs that NICE would not allow because of cost. The effect size of lecanemab and donanemab is 0.25. The drug costs between 60 and 80,000 per year. The rTMS in effect size to treat dementia is 0.77. The machine costs 50,000.
That could treat hundreds,
You can treat
thousands of people.
You can treat as many as you want. Yeah. So one machine, if you have it at home as a one-off cost, well, you can't have it at home, but I'm giving an example, is less than the cost of 1 year's treatment, for 3.5 times more effective. It's been pushed by the drug companies as the panacea for dementia, which it isn't.
Yeah, 0.25 is a very small effect.
It won't do anything. It will do nothing, the course of the disease.
As you described earlier, the placebo effect is 0.2.
Yeah, 0.2 is the placebo. So the change is minimal. And it's being marketed in the US as the thing to do. But the UK, in a way, is good that they did not allow it, because the cost is too high. There are side effects to it, and the benefit is small. So I agree with NICE for a change.
Why is pharma innovation accepted, but technological innovation is not?
Money. Because when you look at medical devices, some of them are more effective than drugs, but they don't have the financial muscle. So the rTMS machines are small manufactured. So the machine we use, MagVenture, is a family-owned business. There is no way they would muster the financial muscle of, say, the Sacklers. That was a family-owned business. Yeah? So money speaks, unfortunately. So they can fire so much money at something that they will succeed. When you look at the opiate scandal with Sacklers, 400,000 died. And it was only because of Donald Trump that it became an issue. Because he went apeshit, as they say, on the deaths from opioid overdoses, and then the Sackler story. So they hid it very well. They knew it was a problem. And the problem is that if I'm responsible for the death of 400,000 people, what would happen to me?
Yeah, you'd be in a lot of trouble.
Yeah. But with the company, they settled.
They get away with it.
They settled for financial sum. GSK was pleaded guilty. So if you look, GSK pleads guilty to fraud. It pleaded guilty to the largest fraud in U.S. history for antidepressant use in children and adolescents. Children, I think. I'm not sure. But, and another drug, I think it's Avandia. But yet, if I'm convicted of fraud, would anyone come to me as a doctor?
No way.
No. So there are different rules to where money plays. If a medical device company is convicted of fraud, a small medical device company is convicted of fraud, what would happen to it? It won't survive. So that's the thing. That's why the medical devices, when you look at rTMS, it's got a much greater effect than medication would have, but it falls low down the line. It has no side effects, yet it falls low down the line. It's not readily available in China. They're now producing portable rTMS machines that you can keep at home. I think over time the technology will make them smaller and smaller, and if and when that happens, it would be much more accessible. But you need a BYD type manufacturer with big muscle to spread it.
And is this your hope that for the future?
I don't think it will happen in my days.
Okay.
I think it will be a long time before that happens. You see it in science fiction movies nowadays. You see when they beam a machine on somebody and they say, we're going to fix this side with the machine. So that's what you hope would happen someday. But I think in our existence, it's going to be drug for now. But as I said, if you use a drug, you must make sure it gets absorbed. If you use a drug, you must make sure that the risks-benefit equation is clearly related to the patient. If you use a drug and it doesn't help a patient within a short period of time, be it whatever length of the study that they've done and said the drug is effective, you must withdraw the drug, not add to it, because it just makes no sense. My view is use rTMS straight away, together with the therapies. There's no harm in it. And I argue that psychotherapy is a form of neuromodulation, with sound as the stimulus, and the thinking that follows is the neuroplasticity, because you start to think in a different way and you apply it. Coaching is a form of neuroplasticity. Physiotherapy is a form of neuroplasticity. Plastis in Greek means to create. Neuroplastis. It's the creation of nerves. So the term is specific in what it means. And plastic surgeon is to creator surgeon, is you create with surgery. So anything that would enhance neuroplasticity, I would go for it. And the more you do something, the better you get it.
I think that's the key of all of this as well. The persistence, the continuation of what works, making sure that you stick with it over time.
Yeah.
What messages do you have for the individual? Because we've said here that the system clearly is flawed and is unable to support people en masse. And as a result, then people are left to their own devices. People hopefully will be listening to this thinking of their individual case or their individual patients and trying to help them. So what messages might you have for that individual who's struggling and suffering, who's been potentially let down by traditional methods?
The first thing is hope dies last. That's what we're saying. When everything dies, hope still survives. So don't lose hope. Number one. Number two, whatever small thing you can do, keep doing it. If you lose hope, you're unwell psychiatrically. You must have an assessment. Ask your treating doctor or clinician or physiotherapist to be screened for depression or anxiety or trauma-related disorder. If these things exist, look at the best way to treat the condition. Look at the options. People are intelligent. People can evaluate evidence. People can form opinions. But their clinician need to be well-versed to advise them of the evidence and the strength of the evidence and why they recommend a certain option versus. So the key is that if you lose hope, we have a problem. And it is psychiatric. It isn't physiotherapy and it isn't a pain medicine. So that's probably the strongest message I would give.
I think that hope message is powerful. I aspire to send all of patients who come into me, certainly with chronic pain, to help them leave with hope. I think that that's part of our job as well as healthcare providers too.
But if they can't have hope, they can't. Yeah, they can't. It's not that they don't want to. And often the patients get blamed. They're not getting better because they don't try hard enough. It is the patient's problem. No, it's our fault. As long as the patient's not well, it's my fault. And I tell my patients, you can always blame me until you get better. And I tell them, I'll have no problems getting you better, but I have a problem keeping you well, because then you will forget when you're better and you'll do the wrong thing.
Yeah, that's the persistence part.
That's the persistence part.
Is there anything else that we've not discussed today that you think is really important for this conversation?
No, I think we've covered it. But just to say that Ignaz Semmelweis was killed. So Ignaz Semmelweis ended up with post-traumatic stress disorder from what happened. And then he engaged in self-destructive behavior, including drinking, frequenting women of sin, as they called it back then. And at the time, it was unacceptable, so they put you in a psychiatric hospital, and the poor man was beaten to death by the orderlies in the hospital. And that was the end of a man who is the only reason why our mothers were alive after we came, because you just asked them to wash their hands.
Are you worried?
No, not really. My lifespan was longer than his. He died in his 40s.
I think you have every reason to be hopeful, and I think that as much as there are frustrations in the story we've spoken about today, there's lots of positivity that's come from the messages you've provided, and what's clear is your passion for helping the person to improve. And our podcast is about inspiring better health, and you've clearly demonstrated that with what you've discussed today.
Health management, not disease management, and we don't work in silos. We all work together. And I tell the patients, we are your servants. We are here to serve you. And you're the boss.
The tagline of our podcast is Better Never Ends. What does that mean to you?
It's always better. It just continues. And that's my argument. There's always room for innovation, and there's always better. I'm always behind. That's how I see it.
Yeah, I think that's inspirational to hear, because you clearly done some good work already in your life. And just finally, if someone wants to find out a bit more about you, reach out or contact you, how would they do that?
They can go on the website. The details of our clinic is there.
Thank you very much for your time today.
Thank you very much, Charlie. I'm very grateful.
Thanks for listening to today's podcast. This podcast is sponsored by Better, provider of health and wellness services in central London. We really believe that we can help people feel better and live better. You can book in for face-to-face services at any of our 3 London clinics. We have one in Marylebone, one in Soho, and one in the city. You can also follow us on Instagram at Better Never Ends, or head over to our website for more information about the clinics or the podcast at www.betterneverends.com.